Greetings from the National Council on Disability, the federal government's independent, nonpartisan advisory body that informs the work of Congress and the administration. We speak on behalf of the interests and concerns of the over 61 million people with disabilities in the United States and in our territories. I am Andrés Gallegos, NCD's current chairman. It is my distinct honor to join you to briefly explain NCD's latest engagement on this incredibly important topic, the dangers of the use of quality-adjusted life years, or the QALY. NCD first engaged this topic of the QALY in 2019 as part of our bioethics series of reports. Admittedly, health economics can be an intimidating one to engage. If you're looking for a primer on the topic, I encourage you to read our report, as it is a good introduction to the issues. You can find it at ncd.gov. In that report, we sought to make the case that QALY perpetuates unequal access to medical care, including life-saving care. In our report, we document the inability of patients with disabilities to access life-sustaining, life-saving, and life-changing medications in countries where the QALY is used. When health insurance will not cover medically necessary medications and treatment, individuals experience poorer health and lower life expectancies. Said differently, the QALY perpetuates health inequities for people with disabilities. Not only does it have a discriminatory effect, the QALY discriminates in design as well. It is a pricing methodology that devalues the lives of people with disabilities. The calculation relied upon by the QALY reduces the value of treatments that do not bring a person back to perfect health, in a sense of not having a disability and meeting society's definitions of healthy and functioning. In that school of mathematics, you can imagine how disadvantaged scores of people with disabilities truly are. Shortly after I became chair of the National Council on Disability on the afternoon of President Biden's inauguration, I announced my vision for the council during my tenure as one that would stay focused on achieving health equity for people across all categories of disabilities. It's my sincere belief that health is the predicate for improvements in living, learning, and earning for people with disabilities. I began my tenure as chair approximately a year into this global pandemic, a pandemic that has unmasked the extent to which explicit and implicit bias against people with disabilities affects treatment decisions. We saw states like Alabama, Arizona, Kansas, Pennsylvania, Tennessee, and others establish crisis standards of care. Guidelines for the use of scarce medical equipment, medication, supplies, and personnel that would expressly base triage decisions on normative quality of life judgments, or that excluded from treatment patients requiring assistance with activities of daily living, or those with certain conditions such as severe or profound mental retardation, those are their words, moderate to severe dementia, and pre-existing conditions that are disabilities. Now I want to be clear. The NCD is in favor of supporting lower drug prices. People across America, including people with disabilities, need access to lower prescription medications. High drug prices themselves can be a significant, if not insurmountable, barrier to access quality health care. But we are not interested in giving policy advice that trades one barrier for another. However, the pursuit of lower drug prices should not be borne on the back of any group of people, and particularly not people with disabilities. We already have a formidable history of experiencing inequities in accessing health care. Misperceptions of people with disabilities on the part of medical providers already lead to low quality of care. There's a horrifying, extensive body of research proving this. In fact, in a recently published survey, it was revealed that 82% of physicians in this country believe that people with significant disabilities have a lower quality of life than non-disabled people. 82%. That's shocking but not surprising for those of us with lived experience accessing healthcare. Here's the shameful reality. Today in the United States, if you're a person with a physical, intellectual, or developmental disability, your life expectancy is less than that of someone without disabilities. As compared to our non-disabled counterparts, you are at a higher risk for early onset of cardiovascular disease. You are more than twice as likely to be obese. You are more than 3 times likely to have diabetes. You are significantly more likely to have unmet medical, dental, and prescription needs. These disparities are exacerbated if you are disabled and a woman, or disabled and a person of color. The existence and extent of these health disparities often have nothing to do with disabilities per se, and are often preventable, but they have everything to do with how physicians see us and how they treat us. Explicit and implicit discriminatory bias within healthcare professions represents an insidious virus against which people with disabilities have been fighting for decades. Where it is used, the quality is an additional embedded bias, cloaked under the virtue of cost savings. Now, what may surprise some is that quality is not a new idea in the United States, nor is the understanding of its discriminatory design and impact. When Oregon first attempted to use quality in its state Medicaid plan in the 1990s, CMS rejected the plan, finding that it violated the Americans with Disabilities Act. And the history of restricted access to treatments occurring in countries utilizing equality raised concerns that its use here in the United States would result in rationed care. That led Congress in 2009 to prohibit or severely limit its use by certain federal agencies under the Affordable Care Act. The language in the Affordable Care Act stated that the Secretary of the United States Department of Health and Human Services shall not use evidence or findings from comparative clinical effectiveness research in determining coverage, reimbursement, or incentive programs in a manner that treats extending the life of an elderly, disabled, or terminally ill individual as of lower value than extending the life of an individual who is younger, non-disabled, or terminally ill. It instructed the Patient-Centered Outcomes Research Institute to not develop or employ a dollars per quality adjusted life year or similar measure that discounts the value of a life because of an individual's disability as a threshold to establish what type of healthcare is cost-effective or recommended. In our most recent advice to Congress, we advise that Congress extend those prohibitions throughout federal programs. The Build Back Better Act is a tremendous opportunity to do so and to memorialize the protections with an unambiguous ban of the use of quality. We remain hopeful that our advice will be heeded as we all await the final text of that bill. I will close with my remarks here with a statement that summarizes NCD's advice to policymakers regarding the use of quality. Decision-making tools designed around measures that devalue the lives of people with disabilities are discriminatory. They have no place in modern disability policy, particularly in light of our current administration, whose leadership has rightly emphasized the importance of achieving and advancing equity. I want to thank you for the opportunity to share my comments with you today.